Okay.
No te oímos, Fanny. Hello, David. Can you hear me?
Yes, I hear you just fine. How are you?
Ah,
I hear you just fine.
nice to see you again. How are you?
I'm very well. How are you? How are you doing?
Bien, bien.
That's good.
Como podemos.
Exactly.
Yes. It's a really situation. It's a very hard situation around the world, of course, but in Spain as well.
I think all around the world, it's been quite a crazy year, quite an insane year.
Yes, but I'm still standing, like like Jack Lennon, yes, like Elton John. I'm still standing, or will stay standing.
But I think everybody's
Elton John.
we're trying. We're all trying.
Yeah.
Give me 1 second. Okay.
Yes.
Okay. I'm just going to try to share my screen, then I'll unshare. I just want to see if it works. Just tell me if you could see my screen. Can you see my screen now? Can you see it's the Spinal Achondroplasia? You can see it?
Yes, perfect.
Okay, great. All right. Okay, and we
are talk about or a short introduction about you, about your talk.
What's that?
And then you can start with your talk.
Sure. I mean, whatever you like. It's whatever you need. That's fine. I'm here for you.
Thank you very much.
Okay. Is it automatically translating? Because it says here that I press this thing called English, or is it?
No, it's tenemos una.
No, I know, but there's this thing here that says
we have a simultaneous translator with Laura. Yes, it's a close collaboration with ALPE.
Hello, Laura. How are you?
Yes, it's in our congress, in our meetings, in everywhere. And she's fantastic.
You're fantastic. Okay, terrific. And she's back away. She's back onto her picture, not the. Okay.
Okay. Fanny, ¿quieres hacer la última explicación sobre la conexión y empezamos? ¿O todo el mundo está?
¿Me oís?
Sí.
Who are you talking to?
Bueno, pues nada, por última vez repito las brevísimas indicaciones sobre la elección de la lengua en la que queréis escuchar esta ponencia del doctor Feldman. Si estáis en un móvil, abajo de la pantalla a la derecha hay 3 puntitos y es ahí donde se selecciona interpretación de idiomas. Elegís el idioma deseado. Si es español, por favor, seleccionad también silenciar audio original para no escuchar los dos a la vez y aseguraros de darle a listo arriba. Si estáis en un ordenador, hay un globo terráqueo abajo de la pantalla y es ahí donde tenéis que seleccionar el idioma en el que queréis escuchar. Recordad que si seleccionáis español, debéis seleccionar también silenciar el audio original. Hello, good evening. Please, I'm just going to give you some very brief instructions about the selection of the language you want to be listening to. If you are on a cell phone, you have 3 little dots at the bottom of the screen. It's there where you have to select the language you want to be listening to. If you select Spanish, please make sure you select as well silence the original audio and make sure that you tick OK at the top after selecting the language. If you are in a computer, you'll see a globe at the bottom of the screen, and it's there where you have to select the language you want to be listening to. If you select Spanish, again, select the silence original audio, so it's not too confusing. And that's it. Please use the chat for your questions for Dr. Feldman if you have some, and remember to write your email at the same time. We'll try to send the answers afterwards. Si tenéis alguna pregunta, por favor, escribidla en el chat junto con vuestro email para que podamos enviaros las respuestas posteriormente. Adelante. Buenas noches.
I put my email in the chat room just in case someone, actually I'll put it to everyone.
Muy bien. Bueno, pues entonces sin más creo que podemos empezar la presentación de esta charla, ¿no? En primer lugar, buenas tardes, buenos días para algunos de los asistentes a esta charla por la diferencia horaria. En primer lugar, daros la bienvenida en nombre de la Fundación ALPE. Yo soy Susana Noval, soy la coordinadora de la Fundación y hoy también nos acompaña el resto del equipo, aunque al tratarse de un seminario web no todas estamos visibles, ¿no? Lo que habíamos hablado hace un momento, que solo están visibles los panelistas y en este caso la traductora. Nos acompaña Carmen Alonso, que es la directora de la Fundación, Estefanía González, a la que habéis ahora escuchado, que ella es la directora de proyectos, y Sonia Sestelo, que es la secretaria. Esta charla está dentro de lo que es un proyecto que en la Fundación llamamos o hemos decidido llamar ADEE Expertos. ADEE es un acrónimo que estamos utilizando en estos últimos tiempos que abarca la acondroplasia y otras displasias esqueléticas que causan enanismo, ¿no? Este proyecto pues, es fiel un poco a la línea de trabajo de lo que es la Fundación, que se intenta divulgar y compartir toda la información que tenemos sobre las ADE y sobre todo sobre las buenas prácticas también y el manejo, ¿no? de estas displasias esqueléticas. Y sobre todo hacerlo llegar a todas las personas que lo necesitan. Personas con ADE, sus familias y profesionales. Pero se trata de hacerlo llegar desde una perspectiva global, desde una perspectiva integral, ¿no? Que es la manera que tenemos de trabajar desde la Fundación. Eso quiere decir que se abarcarán todas las áreas que son importantes para las personas con ADE y sus familias, por lo que este ciclo de charlas no solo serán de contenido clínico y médico, sino que también pues, habrá charlas de contenido científico, de investigación, tan importante ahora mismo, de actualidad. Tendrán un contenido también de educación, que es los pilares básicos de la sociedad, por la escuela, el instituto, la universidad, y tendrán también un contenido de derechos sociales y derechos humanos, ¿no? Como no puede ser de otra manera. Este ciclo de charlas se desarrollará a lo largo del 2021 y estarán impartidas por los mayores expertos a nivel mundial en las ADE. Creemos que son importantísimos, creemos que son vitales porque, bueno, como sabéis, la acondroplasia y las otras displasias esqueléticas están dentro de lo que se denominan enfermedades raras y con lo que nos encontramos muchas veces es con una falta de información, a veces con falta de estudio, y la que hay muchas veces es de complicado acceso a ella, ¿no? Tenemos dificultad para acceder a esa información y a esos estudios, por lo que creemos que es importantísimo crear, ¿no? este proyecto, este ciclo de charlas, esta divulgación de este conocimiento por parte de los mayores expertos a nivel mundial. Sin más, y para no robar mucho tiempo realmente al que es el protagonista, paso a presentar al doctor Feldman, David Feldman. Él es director asociado del Instituto Ortopédico y de Columna Paley y es uno de los mayores especialistas que tenemos ahora mismo en columna y en displasias esqueléticas. Nosotros tuvimos el gusto de conocerle en persona en nuestro congreso internacional en el 2018, al que asistió como ponente. Y tengo que decir, porque tengo que decirlo, que desde el primer momento nos enamoró. nos enamoró. Nos enamoró no solo por su conocimiento y por su experiencia en las displasias y en la columna, sino por su cercanía, por su cariño, por su gran corazón, por el trato que dio a todos los niños, a todas las familias, al resto de los profesionales durante los 3 días de congreso. Y no solo eso, sino que desde entonces y hasta ahora es un colaborador muy cercano de la Fundación, con segundas opiniones, con diagnósticos imposibles, con recomendaciones de tratamiento. Quiero decir, esto es un pequeño resumen para que os hagáis una idea del nivel no solo profesional, sino humano del ponente, del panelista que hoy tenemos aquí. Así que, doctor Feldman, es un placer volver a estar aquí con, aunque sea a través de una ventana con usted, y es un verdadero lujo tener a nuestro alcance todo su conocimiento, y toda su experiencia. Así que muchísimas gracias, no solo por estar aquí hoy, sino por el trabajo que hace día a día. Cuando quiera.
Well, thank you very much for having me. This is, I think I just heard my eulogy. But this is really an honor to speak to everybody about this topic, and an honor, to speak at a group who's dedicated their lives to conditions that are uncommon. And I constantly speak about the fact that I think that there is a relative prejudice amongst healthcare workers and amongst people in society for people who have uncommon conditions. I think that there is a reluctance to find solutions, and a reluctance to have people do the best they can do, because they just say, well, I'll just live with your condition. So that is having an organization that's dedicated to these conditions, and that I feel is so important to improve the lives of all the people with skeletal dysplasias, is really an honor to be involved. And I cannot wait to re-travel to Europe. I've gotten my 2nd vaccine shot today, this morning, so my arm's quite stiff, but I'm very happy. So I hope that will allow this world to reopen someday as we all get these vaccines and move forward with our lives. Without further, I'll talk about this topic, which I really find very important to talk about, which is the spine in achondroplasia. And the reason I think it's so important is because it really is the largest problem that people with achondroplasia have when they become adults. If you go to any long-term studies of achondroplasia, or you go to any chat room of adults with achondroplasia, you'll know that this is the reason for disability as you're an adult. This is the reason why people are not functioning to their full potential as adults. And the question is why, and how do we not allow this how do we solve this problem? And that's in the next half hour or last hour, let's just talk a little bit about this. And I did put my email on the chat room for the attendees as well. And so that you can absolutely see, that's where we are in West Palm Beach, just in this really beautiful sunny area in Florida. But basically, I did leave that for anybody who has questions for me if they didn't have time today, or if they're watching this in a later date in a webinar somewhere, then you can absolutely send me questions about this condition, and I'll try to do my best to answer them. So every dysplasia, and I'm only talking about achondroplasia today, but every dysplasia is very unique. Every dysplasia is unique in the fact that it presents in certain ways of the spine that others do not. So, for instance, pseudoachondroplasia, which obviously we know should have a different name because it has nothing to do with achondroplasia, has C1, C2 instability, and mostly has scoliosis. While achondroplasia does not often get scoliosis, it can, but it does not often, and almost never has C1 and C2 instability. It can, but achondroplasia develops foramen magnum stenosis, which is pressure at the base of the brain when the children are very little. And pseudoachondroplasia does not get that. But spondyloepiphyseal dysplasia will get C1, C2 instability. Morchioles will get severe instability, and metatropic dysplasia will develop kyphosis. So each skeletal dysplasia, each condition should be treated separately. Each condition should be thought of uniquely. And this morning I did a Larson syndrome, and that in its own right is a skeletal dysplasia and can be considered different from these. But we will discuss achondroplasia. So let's, and achondroplasia uniquely forms spinal stenosis, scoliosis, which is not common, thoracolumbar kyphosis, which means you're bent forward, hyperlordosis, which means you have a sway back on the back, and very young kids and even older kids can get foramen magnum compression, and this is quite important to see. And I did talk about this 2 years ago when I was in, or 3 years ago now when I was in Spain, but I think that the neurologic complications often seen in achondroplasia are very slow and progressive. They can begin with just the point that a child with achondroplasia or an adolescent or a young adult or even an adult could be walking along and just need to squat every block or every few steps. And as that squatting becomes more frequent, that means that their spine is compressed. And the reason that people are doing that is because they have compression of the spinal cord or of the dural roots down below. And by squatting, it opens it up a little bit. Sometimes sitting works as well, but I ask that question all the time, and I'll go through a questionnaire with you when I'm finished speaking. What is intermittent claudication? That means it's the same thing that you hear about when you have a patient who has vascular disease. So if you're a doctor and you know that if you don't have good blood supply to your joints, to your limbs, then you will get pain in your limbs. And basically that is the same with spinal claudication, where your limbs will become weak, will become painful over time as you do activities. They can become nerve root compression, so numbness, tingling, and then problems going to the bathroom would be one as well, where there's urinary incontinence, where they can't hold the urine in. And then sometimes I've seen several times where there's an acute neurologic event, where all these symptoms before were slow, and then all of a sudden something happens, like a disc herniation, which people with achondroplasia cannot tolerate because there's no room for that disc to go into the spinal column because there was so little room to begin with, that all of a sudden they become paralyzed, and that becomes an absolute emergency. So we try not to wait for the emergency. So why do people with achondroplasia get stenosis? Well, they have short, thickened pedicles, and the pedicle is the part of the spine that it goes from the back to the front. And if that distance is very narrow, then there's not going to be much room for the spinal cord. And they also thicken lamina, which is the back part of the spine, and they can have the ligaments are hypertrophic, could be very thickened. And usually this happens somewhere when the patients are in their 20s and 30s, but can certainly have them quite young as well. And this is what that looks like. This is the picture of the body of the vertebrae. This is the pedicle. That's that area the spinal cord runs in between. And basically, if this is very short, then there's going to be very little room for the spinal cord. There's where this is looking from above, and there's where the spinal cord is. And if this distance is very small, then obviously there's not going to be much room for the spinal cord. One question you're going to ask is, well, does the medication that we take that's going to become approved in multiple countries soon for achondroplasia taken young, will that cure the spine problem? The answer is I don't know. I don't think it's really been studied enough to answer that question. There's some thought it does not work on these areas because it's not truly a growth plate. But I think time will tell whether or not that the medications utilized will decrease the amount of compression. So where can compression occur? Well, it can occur anywhere in the spine. I left the chest, the thoracic out, but really it can occur up in the brain, where the spinal cord exits the brain, called the foramen magnum, the cervical spine, and the lumbar spine, so the neck and the lower back. And this is really, really important. Foramen magnum compression in infancy is extremely, extremely important. So it is my practice that if a patient calls me who had a newborn with achondroplasia, they should have a sleep monitor. If they have apnea, if they stop breathing at night, then they should be assessed whether this is from foramen magnum compression, from compression of the medulla, that you're not able to breathe, that there's apnea? Or is it from, enlarged tonsils, which can also occur in children with achondroplasia? And you don't have to have one, you can have both. And if there is apneic episodes from foramen magnum compression, then you don't have to wait. It should be decompressed. And this is the neurosurgeon's job, not my job. But I have seen, and especially when I was out in Europe and even in America as well, the complete ignoring of this problem causes global weakness when they're older at best, and at worst, it causes an acute paralysis when the child is sleeping or death. So I think it's incredibly important to take care of this. So when they present, you look at pulmonary function, sleep apnea, upper extremity dysfunction, and this is what you can do for the cervical spine. You can have decompression of the foramen magnum, and you could also decompress the neck, which I find much less common, but I certainly look for it, and I've certainly seen it rarely, but I have seen it in the neck. So in an older person who hasn't had their foramen magnum decompressed, who has changes up there, they may have sleep apnea, and they may be globally weak. And some of these symptoms resolve by age 3, but not always. And in fact, when I get MRIs on these patients, when they're much older, I can see the damage to the spinal cord many years later, which has never resolved. And that really, this should be a never event in my opinion. A child born with achondroplasia should not have a respiratory arrest from their foramen magnum compression, and should not have neurologic deficit or stenosis. And that is one of the changes. An older child, and you can see the foramen magnum is compressed, and there's an injury to the spinal cord, which is permanent. Doesn't mean the patient's permanently paralyzed, but they're permanently something. This is causing some problem, whether it's apnea or just weakness, it's causing some problem. So that is the normal view of the spinal cord, and that's called myelomalacia, damage or fibrosis of the spinal cord at the level of the foramen magnum. Okay, the next problem we're going to talk about in achondroplasia, and this has become relatively controversial, this is a netter picture, is kyphosis. So a child with achondroplasia obviously has a large head and is born weaker than the average child born without achondroplasia. So the question is, should they sit up or should they lie back? And I'm interested in hearing other people's opinion about this. It is my opinion, maybe I'm still old school, that we should allow the children to sit up when they can. Every child is different. Some will do it at 9 months, some will do it at 1.5 years, some will do it at 2 years. But if you rush it, I think this is the end result, is the kyphosis. And I think this has been described years ago. There are some people who think this is not true. The kyphosis exists just by itself and is not caused by early sitting. I disagree, but again, I think we need larger studies to prove that. It usually presents in infancy, but then it can be treated. You just basically exercises or put them down. And it usually resolves when kids are walking by age 2. And this is when we decide modified sitting. And I do still believe in this, other people don't. Braces don't work that well. And it does increase your risk of needing a fusion, and it does increase your risk of stenosis. So I think we should leave kids down until they can stand and walk by themselves, until they can move. And I have found that helps with kyphosis, but you need a large study where half you do and half you don't, which we don't have. And I think kyphosis is not a small problem. There you see a young boy. He was set up very early. He was adopted from China and lives in the United States. And you can see no scoliosis, but there's the kyphosis at a very young age. And this kyphosis actually led to stenosis. So he not only had, he at the level of the kyphosis. So straight spines, you don't get that much stenosis, right? This is the cerebrospinal fluid around the dura, which means there's room. And here you see there's no room, mostly at the disc spaces, absolutely no room. So kyphosis will increase your risk of stenosis. And there's another picture of the same. And this had to be decompressed and fused. So I fused as few levels as possible, let the child grow. And he's done extremely well. And I decompressed the entire spine from here, from T10 to L4 or L5 and basically fused those levels and cured the kyphosis. And this child now is doing just great about 3-4 years later, 5 years later. So I think this is a treatment, but perhaps this is preventable. And that's what I think maybe we could see as a group if it is actually preventable. And this is another patient, and there's no kyphosis. And so in this patient, there was stenosis. And how do I know that? Well, I can see it on the sagittal cuts. I can see the fact that at a disc level it's coming in. But the axial cuts, which you can see here, show it even more. You can see there's no room for the dural roots, especially at this level. None whatsoever. And this patient was having severe symptoms. And this patient I just decompressed without a fusion. Less and less, I think, that I do this without a fusion, and more I do it with a fusion and with a cage in the front at L3-4, which is technical, and we can talk about it if anybody's interested. And you can see it's so stenotic that the dural nerve roots are bunching up like spaghetti before the area. So you don't want to wait this long until there's damage. So what are the symptoms? Well, low back pain, leg pain, painful nerve pain, numbness, a heaviness of the legs, incontinence. We discussed claudication, and it's relieved by squatting. So what are the questions I ask anybody, especially prior to if we're going to do it lengthening? If a patient's going to have, let's say, a stature lengthening for achondroplasia, then risking the patient by doing a lengthening when they have stenosis is unindicated. So I will see every patient at the Paley Institute who will undergo lengthening with any skeletal dysplasia. I will ask this questionnaire. I will likely get an MRI, and then decide, obviously, if the spine needs to be done first, then you can do that before elective lengthening procedures. That is not the same for deformity correction. If it's just a varus or valgus, bow leg, or knock-knee, that can be treated without decompressing the spine. So the questions I ask are, do you experience weakness in your legs? And do you routinely have numbness or tingling in your legs when you walk or you sit? Are you having urinary or fecal incontinence? Are you unable to hold your urine? Are you limited how far you can walk? How far can you walk before you rest and sit down? How quickly after you rest does your weakness, numbness, or pain go away? Do you find yourself squatting after walking? And does this alleviate your pain, weakness, numbness, heaviness? And do you find yourself flexing forward, like leaning forward on counters or grocery carts to alleviate your pain or your legs? And again, if you can have a limit how far you can walk, what seems to be the limit? Means you become short of breath, or your legs just getting tired. And so these are the questions. This questionnaire for me is everything. I can know everything about almost every patient I can know who has achondroplasia. If I really sit down and ask these questions, I can figure out how to solve the problem of what they're having. And it's not always the same. So you could sometimes do without fusion, but if you do without a fusion, you can't get as much decompression. And I'm beginning to think that's probably not a great idea, although there are some articles that still recommend it, and I've had some success. I think fusion allows you really to go away. And when you do kyphosis correction, if you're going to get rid of the back being kyphotic, being hunched, you've got to be very careful about reducing the lengthening of it, because you don't want to stretch the spine in a patient with achondroplasia. So I think that really, in 23 minutes, describes, what I think about the treatment of achondroplasia. And I'm certainly willing, to answer any questions anybody has, about this. And I'll stop sharing. So, and there we go. And I would hope that anybody can ask questions that they have regarding any of these topics. So I think Fanny was here before. Whoever wants to take over, please feel free to take over and lead these questions. I'm not sure I can.
Habíamos dicho, doctor, para que no fuese a lo mejor, no cortase mucho el ritmo de la charla, habíamos dicho que las preguntas podían dejarlos en el chat y nosotros hacértelo llegar, puesto que hay alrededor de 200 participantes y a lo mejor esto se prolongaría mucho. Decidimos desde el principio hacerlo así. No queríamos tampoco robarle mucho más tiempo en la fase de preguntas y que tuviese más tiempo en la fase de la exposición. Entonces, nosotros nos hacemos cargo de todas las preguntas que lleguen al chat, las hacemos llegar y le respondemos a todos los que están aquí, si le parece.
I mean, we could certainly take a few just to see what just to see a few questions, because it just will give me an idea of what people are thinking about, and we can maybe just answer a few. That would be fine. I can't right now. They're in Spanish, so it's hard for me to read them. I see the Q&A. It says, so if you could read them to me, I just answer a couple, and then maybe 10 minutes, and that's fine. It's up to you. If you don't want to, it's okay.
Pues mira, vamos con esta primera. Por ejemplo, que pone, buenas tardes, ¿se recomienda el uso de órtosis para la cifosis? En ese caso, ¿con qué valores angulares?
Yeah, so I mean, I think that if the child is young and it's under 50 degrees, that you can do an extension brace. Most of the time, kyphosis is around T12 or L1, and so a Jewett-like brace, which is an extension type of brace, can be utilized, and there's been some success if the child has a significant amount of growth. And again, maybe if we're using this medication and they're growing faster, maybe that will make the orthotic even more beneficial. But I think if it's just kyphosis, thirdly, that's really very reasonable. If it's very severe stenosis with it, I don't think that would be the answer. No, but not for adults, only for children.
Otra de las preguntas que también a nosotros nos llegan a la Fundación, y aprovecho, es el tema de esa controversia entre entre el corsé desde el principio y no, si agotar al máximo el tema de la rehabilitación, del trabajo de la potenciación, de la musculatura, del trabajo de fisioterapia, antes de buscar, ¿no?, la parte de lo que es el corsé. ¿Cómo lo ve, doctor? ¿Qué recomienda? ¿Eso puede ser una posibilidad?
Yeah, I definitely think that physical therapy is advantageous over bracing, because bracing just makes you weaker. So no question that strengthening the muscles is very important. But in other words, if we're discussing a true structural kyphosis, like the one I showed the picture of, I think in those cases, bracing may be beneficial as well. So I don't think one obviates or one dismisses the other. You can both do physical therapy and you can do bracing. I think both. I don't think you need to choose between the two, and I think that both are probably indicated. Certainly strengthening is definitely indicated, and physical therapy is extremely important in the treatment of achondroplasia in the infancy and as they get older.
Muchas gracias. Mira, aquí tenemos una pregunta desde una familia de Colombia. Bueno, muchas gracias por la información. ¿Cuál es la edad recomendada para la corrección del canal medular estrecho? ¿Afecta aún más el crecimiento del niño?
So the answer that's a really great question. So the question of what age you treat the stenosis, it depends how bad the stenosis is. I mean, so I wouldn't. It's not an MRI diet. Well, first of all, if we're talking about at the base of the brain, in infancy, that should be treated when the child is an infant. Whenever that presents, that should be treated, not delayed at all. It should be treated. If we're talking about lumbar stenosis, which is the lower back, then we're merely dealing with how is it truly symptomatic? Is the child squatting? Can they run still? Can they no longer even walk a few blocks? So the age, to me, it does impact some growth, but not that much. And I think the real impact is, I don't want a child to become paralyzed, and I don't want an adolescent to become paralyzed. So I would say the youngest child I've ever done is about 8 or 9, and I've done as old as 63, 64. So I think that it can be at any age, as long as you're treating the neurologic symptoms, not just the finding on MRI.
Mira, aquí tenemos otra. ¿Hay que tratar la escoliosis antes de abordar una operación de elongación?
So the question was, should we treat stenosis before the lengthening surgery? Scoliosis is what? Yeah, I mean, no. Scoliosis it doesn't matter. Scoliosis is pretty rare in achondroplasia. I've seen it only once, where it was severe enough to treat for a scoliosis. And it doesn't matter much if you have scoliosis and you treat, usually you don't have to treat it surgically anyway, but if you do, it doesn't impact the limb lengthening. Stenosis does, not scoliosis.
Aquí nos hablan de un caso, dice, a mi hijo con 4 años le hicieron una resonancia de Foramen Magnum y no lo tenía estrechado. Ahora tiene 6 años y la pregunta es ¿cuándo debería hacerse una nueva prueba? Pues hemos escuchado casos en los que sí que hay una estenosis, pero no tiene una sintomatología clara. ¿Cuándo deberían volver a tener esa revisión de la salud?
Yeah, I mean, it's very rare. It's very rare to not have stenosis at age 4 and then to have it at age 6 or age 10 or age 12. I think if the child was having very bad snoring and having apnea, then that would be a time to reassess the problem. Is it the tonsils or is it something centrally? But I think that it's incredibly, I'm sure there are stories, but it is very uncommon to not have stenosis in the foramen magnum at age 4 that's developed at age 6. Because usually the foramen magnum stenosis is a problem of infancy, is a problem in children under the age of 3. So I wouldn't necessarily do an elective MRI.
Bien, hay una pregunta aquí en inglés, pero bueno, la ponemos igual. Dice que si hay algún tipo de estilo de vida, de ejercicios que puedan reducir el riesgo de la estenosis que requiere cirugía, por ejemplo, pilates. Ahí lo dejo.
I wish. That's a great question. I wish. No, I don't think so. I think that the problem is it is a structural problem in the spine. It's not about muscle strength. It's not about fitness. It's just about luck. I've met some kids with achondroplasia and adults who don't have any stenosis, but I've met plenty that do. So I don't think it matters about weight or about how fit or what they eat or what you do at exercise, unfortunately. It just is a structural problem. Obviously, it's always good to stay fit and keep the core strong, and that helps in many other ways, but I don't think it truly helps in terms of stenosis.
Perfecto. ¿Tenemos tiempo para alguna más, doctor?
One more. Sure, one more is great. Sure.
Venga. ¿Los alargamientos de extremidades mejoran o corrigen los problemas de la columna?
That's a good question. That's a good thing to end on. So limb lengthening has a potential to aggravate a spinal problem if it already exists. It doesn't cause spinal problems usually, but if there is spinal stenosis, it can aggravate that because it pulls on the nerves as you're lengthening. And there's been a couple of reports after lengthening of someone becoming paralyzed. So that is why at Paley Institute, we always have an MRI and do that questionnaire beforehand. It does help a little bit with the lordosis. If we correct the hips a little bit, then that will correct some of the lordosis of the spine. But in terms of stenosis, it can only uncover the problem and not be beneficial for it. So that's why we are very, very careful about making sure the spine. I review every MRI of every child undergoing a lengthening at Paley Institute with achondroplasia before they have it. And I go through that questionnaire in every single patient.
Bueno, pues la verdad es que el tema es interesante. Siempre a nosotros, a nuestra organización, nos llegan muchas cuestiones de este tipo. La verdad es que qué mejor, ¿no? Qué mejor experto para poder aclarárnosla. Quedan un montón de preguntas, pero como he dicho al principio, no os preocupéis porque nosotros se las vamos a hacer llegar al doctor y como es habitual en él, siempre nos contesta, siempre está ahí al otro lado del email o al otro lado del ordenador, así que no os preocupéis porque en cuanto tengamos sus respuestas os las haremos llegar a los emails que nos habéis proporcionado. Yo no sé si quiere añadir algo más, doctor.
Thank you all very much. No, just thank you very much. And Susanna, thank you. And everybody, thank you very much for allowing me to do this. And Laura, thank you for translating. I really appreciate it. I think that we should, these conversations should continue, hopefully over a drink someday in person, and we can all go back to normal. But I appreciate everybody. Have a terrific weekend, and thank you very much for inviting me.
No, muchísimas gracias. Reitero el agradecimiento por parte de la Fundación. Nosotros también desde aquí, bueno, pues agradecemos públicamente que, como sabéis, el patronato de nuestra Fundación, de la Fundación ALPE, es el que hace posible, ¿no?, este soporte incondicional que nos llevan dando durante 20 años, que hemos cumplido el año pasado. Este año a ver si podemos celebrar el 20+1. Así que, bueno, también nosotros públicamente queremos no solo dar las gracias al doctor, sino también a todo el equipo de la Fundación, que aparte de las que he presentado también tenemos la fisioterapeuta, el ortopeda, la logopeda, nutricionista, psicóloga. Bueno, sabéis los que nos conocéis que es un equipo multidisciplinar fantástico que hace posible que este tipo de proyectos se lleven a cabo, en especial a todo el patronato de la Fundación, en especial a nuestro presidente Philip Press, que es el que lleva desde el principio con nosotros y hace que podamos seguir haciendo este tipo de proyectos que creemos que es interesantísimo y tener la posibilidad de tener a expertos del nivel del doctor Feldman que hoy tenemos aquí. Le emplazo a, bueno, a posibles y futuras charlas y no solamente eso, sino a cuando esta situación nos deje celebrar nuestro Congreso Internacional, si no es este año será el que viene, estaríamos encantadas y felices no solo de tenerlo al otro lado del ordenador y del teléfono, sino otra vez en persona, que siempre es un gusto compartir tiempo con usted. Yo creo que sin más podemos dar por finalizada esta charla. Esperamos desde la Fundación que haya sido de ayuda, una pequeña aclaración, un pequeño conocimiento. Evidentemente hay mucho que hacer, pero para eso seguiremos trabajando. Como os dije, a lo largo de todo este año, pues todavía dependerá un poco de la disponibilidad de los expertos, la frecuencia con la que las hagamos, si es 1 al mes, 2 al mes, más espaciado, pero no os preocupéis porque sabéis que os mantenemos siempre comunicados y esto continúa. Muchísimas gracias por estar aquí. Hay personas de todas las partes del mundo, he estado viendo todos los participantes, así que nos alegra muchísimo poder llegar cada vez a más personas y a más lugares del mundo, ¿no? Como decimos, se trata de enfermedades raras y no siempre está a nuestra disposición esta información y este acceso a grandes profesionales como el doctor Feldman. Sin más, tengáis buena tarde, buen día para los que estáis más alejados y nos vemos en la próxima.
Bye-bye now. Bye.
Adiós.